So good morning. Let's go back to theory again. When somebody hears this title, Orthobiologics and elbow tendinopathy, they might wonder, what does this mean actually? So if you visit the site of the American Academy, it would say that there are orthobiologics are therapies developed from biologic substances that can be used to help relieve pain and other symptoms, to enhance the body's ability to heal in some cases of injury like ligamentous or tendon strains, but even fractures. And then, of course, it improves healing. There are several types, like composed of sugars, proteins, nucleic acids, or complex combinations, but they could be living entities as well, that means cells. Examples are stem cells that are not used clinically yet, and blood products such as the famous PRPs and autologous blood concentrations, and then viscous supplementation stuff like hyaluronic acid. To be more specific, the typical orthobiologic treatments include autologous blood-derived formulations, PRPs that means, and autologous conditioned serum, and then cell therapy products coming from bone marrow, adipose tissue, and perinatal sources. There are other currently available approaches like extracellular matrix patches and the scaffolds, purified cytosines and small peptides, and repurposing of medications that are FDA approved for other indications. We want to use those in order to treat elbow tendinopathy, which is actually, as we know, an angiofibroblastic hyperplasia with disorganized collagen and vascular hyperplasia without inflammatory cells, but with macrophages and lymphocytes, maybe. And if we want to treat this, we need to know what's going on there. So we know that tendons typically function at the 30 or 40% of their maximum tensile strength, and they are injured when exposed to supramaxillary loading. And because of their low metabolic rates, when they function under prolonged stress, they can be injured, and because of the delayed healing, we are led to a degenerative condition with pain and dysfunction. It's important to understand the pathology there in order to develop an effective treatment, not only for pain relief, but also for tendon healing. And that's what we have not yet managed to find. Because the precise cause of degeneration and pain is not clear. It could be mechanical, vascular, neural, failure of healing, but we don't know yet. And also, there are so many treatment modalities that only show that we haven't found the ideal one. As we know, the treatment is controversial. There are many studies advocating different techniques, but generally it could be considered a self-limited problem, best treated non-operatively. So what do we do in order to use orthobiologics in tendinopathies? We inject them. And we're going to talk about the famous one, PRPs, first. So, as we know, PRPs are prepared from autologous whole blood, which is centrifuged to concentrate platelets in plasma. And that's because we know that platelets contain at least 6 platelet-derived growth factors that are known to improve soft tissue healing and bone regeneration. But the problem is that there is a huge heterogeneity between these formulations that we use in order to inject them. Also, they're not well classified. There are only 2 classifications. They're either leukocyte-rich or leukocyte-poor. But, and we talk about leukocytes because they produce pro-inflammatory mediators and other catabolic proteins. But a much more refined analysis is needed, that simple leukocyte rich versus poor, because there are so many other factors that can contribute to treating the complex problem that we have to deal with. So other considerations are the ratio of platelets to leukocytes, the total number of platelets, the leukocyte differential, and also all the signaling molecules beyond the growth factors that we need to precisely calculate. So these preparations, they have a platelet concentration that first the literature promoted the concentration of 2.5 to 3 times the baseline in order to be effective. But then the current body of literature suggested greater concentration in order for the tissues to heal. Also, the leukocyte concentrations are not very clear. The use of activators are not estimated, and the pH of injectant, and also the local anesthetics that we usually inject them with, that now multiple studies have shown that they lead to decreased tenocyte cell proliferation, so decreased cell viability. So if we inject it with a local anesthetic, we're going to end up maybe not doing anything. I mean, and then there are so many papers that are trying to come to a conclusion. For example, so many comparisons like PRPs versus corticosteroids, or glucocorticoids and saline, and or autologous whole blood, and so on. And usually they show us maybe better results in terms of symptoms relieving and not structure modifying. But then they're not talking about the same solution to the same kind of problem. So the classifications that exist only count the leukocytes, but not the concentration of the platelets, the presence or absence of white blood cells, and whether the PRPs were activated with exogenous thrombin or another mediator. And then we don't know if a single injection would be okay, or we need more than that. And there's a huge body of literature about that as well. Also, there is not a typical kind of patient with tendinopathy, and this is another factor. So it's not, we need to take in mind what kind of patient we have in front of us, the age, sex, and the type of degeneration. All the double-blind papers, trials of many patients concluded that there are no significant differences between the PRP injections and a placebo. Some other papers show that it is superior than the whole blood products, and the volume of the injections is important. And then there are other clinical studies that compare treatments, but the conclusion from all that is that actually we compare pairs with I don't know, chairs. I mean, there is so much heterogeneity that we cannot come to a safe conclusion. So there are other kind of orthobiologic therapies, for example, cell therapy approach, like stem cells. But there is a confusion about the MSCs, which are cultured mesenchymal stromal cells, and the CTPs that are connective tissue progenitors, so freshly harvested cell populations. And these are really different, and in the literature, they're used as the same thing. So there was this nice paper from Kaplan that he described first the MSCs in 1991. And well, it is really important to distinguish the two different kinds because they have different properties. Also, although there was a robust literature that demonstrated a positive effect, using the culture expanded cells in animal models, there are no clinical trials. So still, we cannot use them. And then there are so many alternative sources, but they're still in a trial level. So there are progenitor cells that derive from subacromial bursa. Also, stimulation of intrinsic progenitor cells that reside in capillary walls have been used in animal models. They're called pericytes. And then cells derived from perinatal birth tissues like umbilical cord, bloods, amniotic fluid, amniotic membrane, placenta, and Wharton jelly. All of those, of course, cannot be used clinically yet because there are federal regulations and because rigorous clinical trials are not yet made. And then there are exosomes. Exosomes are extracellular vesicles that are released from the cell on fusion of a multivesicular body with a plasma membrane, and they contain the cell cargo, meaning numerous proteins, lipids, nucleic acids. These would be a nice idea because we could have the benefits of cell therapy without the logistical challenges of the cell harvesting, culture, and implantation. But of course, they're still in the area of research. Also, there are other orthobiologic approaches like gene therapy, the small peptides and purified cytosines, repurposing of FDA-approved drugs. This is the only thing that is already used. For example, Miller in 2016, he studied secukinumab, which is an antibody that attaches to interleukin, I think 17A, and it is used for psoriasis and psoriatic arthritis and so on. And now it shows that most probably by inhibiting interleukin, maybe tendinitis could heal in a better way. And then there are extracellular matrix scaffolds. Now, in conclusion, in the use of biologics for the elbow, it seems that unfortunately there is no evidence-based how can I say, conclusion in order to verify our use. They have, of course, tremendous potential, but still there are many unanswered questions. For example, the basic laboratory studies to characterize the composition, biologic activity of all of these materials. Also, the data should be correlated with the clinical and imaging outcomes in treated patients, and the linked clinical registers and biospecimen repositories are needed. Yet, the identification of the important sentinel markers of cell purity, potency, and biologic activity for different tissues and pathologies will hopefully lead to the identification of the tests that can easily be done to the point of care, clinical operating room, allowing more precise matching of a therapy to the patient and their pathology. And also, we need to find the pathology that could be treated with the right orthobiologic treatment for the right patient. So there is a long way to go yet. And some papers say it in the title that in the treatment of lateral epicondylitis, for example, by percutaneous perforation, injectables have no added value. There is a long way to go, but of course, by continuing with our searches in cell therapy and the other orthobiologic treatments may finally lead to a nice outcome, because as it seems, the PRPs and autologous blood that we used have no added value for tendinopathies.
Thank you very much. Thank you.